I've been asked to speak, not really on behalf of NHS England, but really more broadly about the role of nurses and nursing in AMR. And to be honest, when Paul and the team, when we first sort of discussed the talk, I initially thought, I'm not sure I can talk about that. Because I'm a nurse. So I thought, well, wouldn't you be better? I can point you in the direction of one of Kieran's team. There's 7 of them. I'm sure one of them can come and talk to you about the role of... And then I sort of took a deep breath and I sort of thought, well, actually, hopefully I can explain to you why I actually think nursing and nurses are really, really important to AMR. And it might be that when people show us I'm not trying to generalise, but when people show us, or particularly me, I'll talk about me, sometimes when people show me a graph, I start twitching a little bit. And sometimes when people show me a spreadsheet, I start to twitch even more. So that might be you, that might not be you. But actually, even if that is you, we can still have a really great role in AMR. And actually, I want to argue with you that actually I think we're probably pretty central to some of this work. So that's what I'm going to talk about. I'm going to try and take us from the role of perhaps what one might classify as a bedside nurse right through to the role of some of the strategic leaders, I know great leaders we have within nursing, and possibly show you and discuss with you what I think their role might be. So Kieran mentioned that one of his last slides is one of mine, and this is another slide that I've got to thank Kieran for. So if we start initially thinking about what stewardship is, and hopefully the next bits will come up if I press the next button, or maybe they won't. Stewardship's about protection. Stewardship's about protecting the environment. It's about protecting and holding on to things that we need to care for, and we need to care for so that we can look after them, so that they'll be there for us in the future. And that's what I'm hoping. Oh yes, it does work. So protecting resources, protecting assets. Conservation, preservation, and protection. But if we think about what antimicrobial stewardship is, well, I think Kieran has already probably very well explained what antimicrobial stewardship is, yet we know 1/3 of the population think that antibiotics are effective for viruses. We also know that those with health inequalities and deprivation or ethnic minorities are much less likely to have had any advice about antimicrobial stewardship. And I'm going to return to those themes later on. But as I think our first speaker said, it's not all about restriction. And actually, what we're actually talking about is optimising the best outcomes for our patients and our service users. So when we're talking about AMS and what it means to me, for me, it means that the highest quality of care is provided to every one of our patients, so that they get the correct diagnosis, the correct treatment for the right length of time, and don't suffer any complications. And that's really what I'm talking about. So if we then look at the role of nurses and nursing, I really think that's central to a nurse's role. But thinking about, well, what does the World Health Organization tell us about antimicrobial resistance? Well, that tells us that antimicrobial resistance is about hygiene, it's about disease prevention, it's about patient education, and it's about diagnosis. And again, I would argue all things that are central to the role of nurses and nursing, regardless of the role you have and regardless of what you're employed to do. Kieran's already mentioned the National Action Plan, but again, there are several things within that plan that are the roles of nurses and nursing. I won't go through that again, but I'm sure as Kieran was talking, some of that work is familiar to many of you. But actually, it's not just about our professional roles. I would argue, and I was just talking to Kieran before we started about my son. So my son has a heart condition, which means he's at risk of something called endocarditis, which means every time he gets a respiratory infection, my GP sometimes can panic. And I've got lots and lots and lots and lots of backup prescriptions for him. Very few of them are cashed. But I'm in the fortunate position of being able to make an informed choice. I'm in the fortunate position of being able to think about antibiotic resistance, about being able to think about the fact that one day he may, well, it's about 80% likely he will need some sort of invasive surgery. So what I want for my son is the ability that when he's in intensive care, paediatric intensive care, that the antibiotics that his clinicians decide are appropriate at that time are going to be effective, and that he's not going to be resistant to any of them because I've spent the first 12, 13 years of his life giving him antibiotics when possibly he didn't need them. And I can appreciate, for all the reasons that I know you're all familiar with, why some of those prescriptions happen. But again, I want the appropriate clinical outcomes and the safest outcomes for him. And that's why it matters to me as a parent, but it also matters to me as the daughter of an 80-year-old woman who I was delighted the other day. She was prescribed a broad-spectrum antibiotic by her GP, who told her to stop her omeprazole while she was taking it. She only takes it for indigestion. There's no risk of any complications, but I was delighted that her general practitioner said, stop taking that during the course if you can. Obviously, if you've got any complications, come back to me, ring the surgery back. But actually, it was what was appropriate for her at the time, and he considered that as part and parcel of her treatment. So just returning to nursing and the role of a nurse, when you think about nursing and what nurses are called to do, what's on our professional register, if you are a registered nurse or a nursing associate, we're actually called to reduce harm, prioritise people, practice effectively. And aren't all of those things what the first two speakers were talking about? Aren't all of those things what Kieran was just talking about in terms of optimising patient outcomes? So it won't be a shock to you to learn that the RCN and many organisations actually fully support nurses being involved in antimicrobial stewardship. But what does the literature tell us? So the literature tells us that actually there are a number of roles nurses can take, and Kieran's already alluded to my final slide that I have unashamedly stolen with pride, and that's nurses' role at the bedside, and primarily here at the bedside. So generally speaking, it's nurses and nursing that take diagnostic specimens. How important is it to have that specimen? I used to work in an acute trust, and I frequently, my microbiologist would bemoan to me that when we started SMART and then focused, he couldn't focus because nobody had taken a sample. So that patient that came in, query UTI, query chest infection, deterioration falls, i.e. everything, nobody had taken a sputum sample, nobody had taken a urine sample, so how on earth were they supposed to work out why they were septic because they didn't know what the thing was? So I think nurses have got a huge role in making sure diagnostic samples are taken. We've also got a huge role in checking the initial prescription to making sure that we're administering the right drug at the right dose, the right time, etc. And that's part of our registration in terms of the administration of medicines. We've got a huge role in terms of monitoring for adverse side effects. It's us that are there at the bedside with the patient 24/7 if you're in acute care, who can actually work that out. We have roles in taking bloods, for looking at blood levels in terms of antibiotics, and we've got a big role in discharge counselling. So colleagues tell me now, huge push to get patients out, but actually who's taking that role in terms of discharge counselling, and community nurses feeding back to me that patients are coming home with almost I'm sorry, but they're telling me they're coming home with a bag of medicines and they're waiting for the community nursing team to come around and explain what's in the bag, and they haven't taken what's in the bag for the last 2 days because they're still waiting for the community nurse to come around and tell them what's in the bag. And I've not just heard that story from one team, I've heard that story from many. So nurses really do have a role. Another study, Castro-Sanchez et al., looked at roles at the bedside, but he took that a step further, and that's why I'm going to move away from the bedside, and looked at the role nurses have in quality improvement and in surveillance. Now, nurses and nursing have done huge amounts in terms of quality improvement over the past few years. And it's really, really important that some of those quality improvement projects really start to embrace AMS. Another study by Tonner et al. Looked at who comprised an antimicrobial stewardship team, and you'll see there lots of teams there reporting, this was back in 2014, the nurses that they've got within their team. But most papers relate to acute or inpatient provision of care. And really, I suppose it's fair to say, I think, really, that the roles are not well researched and their impact particularly is not well understood. And I think that's probably because as nurses, again, we don't tend to, and I'm very generalising here, we don't tend to come forward with research possibly as well as other professions. That's probably a fair point to make, and there's an awful lot we could do if we actually remember to write up some of that good work. How often have you seen something presented at a conference that I've been doing that for the last 10 years? Because you didn't write it up, somebody else has come forward to present that information. So thinking about some of the barriers, some people think, as I did, I haven't got enough experience, don't ask me to do it, I can't do it. And that then becomes the conversation whether you're talking at the bedside or within an acute provider for nurses stepping forward. Equally, some of the studies report issues with hierarchy and power within organisations and some issues around silo working. So some of those relate to organisational culture, and some of those, again, require strong nursing leadership at high levels within the organisation in order to help nurses and nursing break through that within their organisations. And finally, just probably in the last sort of 5 minutes or so, I wanted to come on to the role of systems. And Kieran mentioned in his talk about the role of integrated care boards, integrated care systems. And you can see there, I've taken that from the King's Fund, but the sort of 3 key priorities are about health inequalities, about enhancing productivity, and about helping the NHS with its broader social and economic outcomes, all of which Kieran's alluded to in terms of some of those sort of more precise aims. So if you think about that, each ICB has got a chief nurse. Each ICB has also got a medical director and other people as well, of course. But actually, I would argue the system has got a huge role in AMR, and that's why we've sort of wrapped around some of that support that Kieran's already alluded to. But then if we go back to the slide I originally put up, about a third of the population think that antibiotics are not effective for viruses, and about those health inequalities and that effect of deprivation. And we think about how much deprivation there is and how many health inequalities, particularly in the north of England, parts of the Midlands, pockets of southern areas. And then we think about what those ICBs that are centred in those areas are charged with doing to reduce those health inequalities and to improve patient outcomes. I would argue again that AMR is central to some of that work. One of the chief nurses, this is again taken from Carolyn Maurice's blog, I suppose, on NHS Futures. And again, sign up to NHS Futures. There's loads on there if you haven't already. But she talked about her new role as a chief nurse within an ICB and how that gave her greater opportunities to transform services and to provide leadership. And I would argue if your ICB hasn't got AMR forward and central to all of their strategic objectives, they're not going to achieve the outcomes that have been set for them nationally, because AMR is going to be central to that work. If we look at NHS England's operating framework, and you might not be able to read some of that, but it talked about achieving the priorities of the long-term plan. It talks about population health. It talks about the role of the ICB in achieving and tackling reduction in health inequalities. So Kieran already alluded to the long-term plan, but I would strongly argue if we reduce infections, there will be less need for treatment, therefore less resistance and reduced costs, and will reduce patient safety. And that really is central to what the role of the ICBs have. So what I want to share with you really is I've taken this and I've tried to come up with this myself, so apologies for possibly a bit of dodgy graphics here. But when you look at the long-term plan, it talks about doing things differently. It talks about preventing and tackling health inequalities. It talks about getting the most out of taxpayers' investment in health. It talks about making better use of digital and data technology. And they're all the things Kieran described in his first talk, and therefore the role of a nurse and the role of a chief nurse and the role of a nurse in leadership within the ICB. Sorry, So one of the things that is also available on NHS Futures in the quality part of that is some draft quality functions of the ICB. Now, these are only in draft. That's why I haven't got a reference on them. They're initial thoughts as to what some of those quality functions might be. And ICBs have been asked to make provision for AMR in their oversight and governance arrangements. They've been asked to identify a lead. They've been asked to think about surveillance, understanding what their key areas for actions are, and to consider infection management when drafting strategic plans. And again, I'd challenge back to you, if you're obviously whether you're from a provider or whether you work within an ICB, is that central to your core functionality of the ICBs that you work with? So just to give you an illustration for that, if we think about antimicrobial stewardship and long-term conditions, so thinking about the area I primarily work with, which is UTI reduction and reduction of catheter-associated UTIs, that requires continence management. It requires hydration. It requires looking at falls, fractures, skin integrity. All of those things are not infection prevention and control. All of those things are actually nursing quality. All of those things are about safer patient outcomes. So when we ask for infection prevention and control and AMR to be everyone's business and to be central to what you do, that's what we mean. That's what it means in practice. It means system thinking. It means putting some of that leadership in place. So just some take-home messages. Nurses of all grades and roles have got a place to play in AMR, regardless of what you do. We've also got our individual role within our communities and with our families and with the people we know and those around us. We've got a role at the bedside. We've got a role in our organisations. If you work for a provider organisation, you can lead on quality improvement, surveillance, education. And there are great potential there for further development of some of that work and for writing it up, if that is indeed your role. And finally, in our systems, or our nursing leadership, I believe, are in a unique position as these ICBs take their first steps forward out of the pandemic to place AMS at the centre of everything they do to improve health outcomes, prevent harm and protect our populations.